First, I want to welcome Dr. Raman Muthusamy and Dr. Adarsh Taker. Thank you so much for taking time out of your evening to chat with us tonight and kind of help us move the needle in what is really an important disease state. I know we've talked before about April being Esophageal Cancer Awareness Month, and I feel like that would be a great place to start. And Dr. Muthusamy, if you don't mind, could you kind of lay out for us, GERD in general? What is the impact that it has on the population today? And if left untreated, how can it be progressed to something more serious, potentially even esophageal cancer?
Yeah, good evening, Courtney. Thanks for the opportunity to join you this evening. So, as you mentioned, GE reflux is one of the most common medical conditions, period. It's certainly among the very top reasons why patients, see GI physicians or even primary care physicians. If you take a look at some studies, the impact on quality of life, missed work, other things is really quite substantial. In fact, some studies have compared it even to some forms of angina or cardiac disease. It affects probably, 50 to 60% of the adult US population suffers from reflux at least once monthly. And we know that based on medication use, over-the-counter medications, that probably the majority of the adult population is using some form of anti-reflux medications every month. And so it's a huge impact. The concern is, well, what does it matter? And of course, we know that chronic reflux is a predictor of the development of Barrett's esophagus, which is the precursor lesion to esophageal cancer, which is the fastest rising cancer in the United States over the past 40 years. And once you get esophageal cancer, unfortunately, because most of them present in an advanced way, the 5-year survival for that is 17% if you take all comers. So we're obviously trying to prevent people from getting Barrett's esophagus if at all possible, obviously focusing on early treatment. And other complications from chronic reflux include anemia and developing esophageal strictures. So there's lots of reasons to want to control reflux today.
Thank you for that background. Dr. Thacker, you and I have had a conversation about, Dr. Muthusamy just kind of laid out the importance of seeking treatment, right? But if you could kind of walk us through just some background of GERD. You explain GERD as kind of like a flavor, right? Everybody's got a little flavor. So can you walk us through, how you think about GERD and how you approach it with your patients?
Sure. So, and again, thanks for setting this up. It's good to be able to chat with everyone. So essentially, I'll kind of take you through it the way I talk to my patients. And as an interventional endoscopist, usually the patients coming to see me have already kind of spoken to someone or tried some kind of GERD therapy. But I like to break it down kind of in its entirety and lay the whole spectrum of options out for them. And so when they start talking to me, when I'm really trying to get at what their symptoms are, I think most of the gastroenterologists know that GERD really, and really the surgeons too, that GERD is a spectrum. So there's the type of GERD where it's really the kind of the classic heartburn and maybe liquid reflux or regurgitation. There's the GERD that may be more regurgitation predominant. There's the atypical symptoms, throat symptoms, coughing, and then there's kind of the more dyspeptic symptoms where you're not exactly sure whether it's truly GERD, but maybe response to PPI therapy. So every GERD patient may be different. They might have a different pattern of symptoms. And so one of the things I try to do when I'm assessing him, kind of fast forwarding to figuring out how I'm going to treat them, what options they may respond to, is what flavor of GERD are they? Are they more of the kind of the symptoms of heartburn only? Or are they someone that, for example, when they change positions, they are getting frank reflux, frank regurgitation of liquid or food contents up into their throat? Are they daytime or is it nighttime? Because that might give me an idea of if it's positional and maybe more of a very open valve versus if it's a daytime, maybe after meals, it might be that they're having relaxation of their valves more frequently than others. And so that's, and then there's others where maybe it's only extra esophageal manifestations such as throat symptoms, chronic cough, hoarseness, etc. And so not only am I kind of thinking about their symptoms of what might be going on anatomically, but also it helps me kind of set expectations on what symptoms may get better or may not for all the various treatment options we have, from kind of the least invasive to the most aggressive.
That's great background. You mentioned that there's more to GERD than just the lower esophageal sphincter, right? Can you walk us through the mechanism and cover the three parts of how you identify them?
Yeah, so when I kind of describe to patients what their treatment options are, I kind of set it up in terms of what happens with swallowing and with reflux. So essentially, when they swallow, the esophagus, kind of a tubular organ that will propel food down from the throat down to the bottom of the esophagus, and then there's a circular muscle, the lower esophageal sphincter, which will open, allow the food to go through, and then typically stays closed. Now that can relax more frequently than it should. But the lower esophageal sphincter, while it gets a lot of the attention for when we're talking about reflux and anti-reflux procedures, there's really a couple of other major factors in preventing reflux, or kind of our entire gastroesophageal valve mechanism. One of them is if the lower esophageal sphincter is actually what we call the inside valve, the outside valve is actually the crus of the diaphragm. So it's the right crus of the diaphragm actually will wrap around the esophagus. And for anyone who's performing an endoscopy that's normal or looked at a normal barium esophagram, the esophagus takes a little bit of a sharp turn right at the bottom before it reaches the GE junction and the cardia. And that's really kind of like a noose or a hook of the muscle of the diaphragm hooking around the esophagus and creating an angle there. And that's an important mechanism in preventing reflux. It's kind of like you're folding a pipe to prevent fluid from moving through. And so when the diaphragmatic hiatus is too wide, you may lose that angle, or you may have a frank herniation of the top of the stomach up through that hiatus, and that's when we refer to it as a hiatal hernia. So when gastroenterologists are typically talking about the hiatal hernia, they're talking about the axial length, so the sliding of the stomach into the chest. But a surgeon may describe it as actually the diaphragmatic hiatus being a wider diameter. So they may measure it in the kind of the different plane. And so I talk to patients about that. And then the third thing I mention is what we often forget about are the sling fibers, or those oblique muscles in the proximal stomach. And there's Dr. Sedarat, fresh off of a busy day from endoscopy. Good of you. Good to see you there. But these sling fibers, which we know communicate with the lower esophageal sphincter and they connect with the stomach, are responsible for that angle of His. So that kind of sharp angle between the lower kind of gastroesophageal junction and the fundus of the stomach. And that sharpness actually also creates a little bit of floppiness in the lower esophageal sphincter, the valve mechanism. And so our natural valve really should be kind of a floppy flap valve that prevents liquid from refluxing up. So this kind of sets the stage with what treatment options a patient may have. And really what I'm getting at is that I need to look at their anatomy and see their anatomy really well to figure out, is theirs just an issue with the lower esophageal sphincter opening too much? Is it an issue with their diaphragmatic hiatus being too wide and they have a herniation? And could it be an issue that the sling fibers have kind of relaxed, or because of the herniation, they've lost that angle of His? And so those really are the three mechanisms: the inside valve, the outside valve, and that angle, which kind of guides me to my strategy for them.
That's great background. Thank you, Dr. Thacker. Hi, Dr. Sedarat. Thank you so much for joining us. It's great to see you.
Good afternoon.
I want to put this out kind of to all three of you, and we can kind of make a discussion of it. But based on the existing options that are offered to patients between lifestyle changes and, you have the other end of the spectrum, right, with more traditional anti-reflux procedures. What's your thought process on how to bridge the gap between the two treatment options? Dr. Muthusamy, do you want to take that one first?
Yeah, I mean, a lot of these things, this is something that occurs in a lot of areas of medicine, which is sort of step up or step down, right? Do you start with the sort of least aggressive thing and work up, or do you start with something that's considered to be more aggressive and go down? And there's a lot of, studies, at least in Gerd, showing, at least when it comes to pharmacologic therapy, that, perhaps starting with a more definitive therapy may actually be better, rather than, trying a bunch of things that fail and then going in. And we know that lifestyle modifications will not work in a large number of people. There's a growing number of people who are uncomfortable using pharmacologic therapy long-term. So even though it works, and it's actually helpful for us to know that it works, because it can rule out that group with functional heartburn where perhaps a definitive procedure may not be the most appropriate choice. But then there's certainly a group of people who still want to avoid an operation if possible. So, an endoscopic option, or an endoscopic option coupled with a minimally invasive surgical option like a hernia reduction, certainly seems attractive, and certainly we know that laparoscopic, fundoplication, Nissen fundoplication in particular, is associated with a large number of side effects, particularly gas bloat and dysphagia. So, so for those reasons, it probably it's nice to have an option in the middle to sort of provide a full spectrum.
That's great. Thank you. Dr. Thaker, Dr. Sedarat, do either one of you want to add anything else to that?
Yeah, I mean, I think that's all well taken. The point is just having a tool in the armamentarium and recognizing there's a spectrum of anatomic abnormalities and picking the right patient to do a TIF in versus, someone who needs a hiatal hernia repair and a fundoplication. I think it's just a matter of understanding where in the spectrum this particular tool fits and then applying it.
Yeah, and I think just to kind of close that same thought, I agree. It's that I want to set expectations for the patient. So if they do go down one option and it's not maybe the best fit for them, then they shouldn't expect that they're going to get 100% improvement. And so understanding kind of what may be the good option for them is I think good to kind of discuss what the outcomes may be after whatever they decide to do.
Thank you both for adding some color. We have a question that I want to bring up, and Dr. Muthusamy, I'm going to send this one over to you, but feel free for everyone to chime in here. Abigail asks, patients who work third shift or overnight hours suffer from Gerd at a higher percentage than patients who have a more quote normal schedule, right? Do you have any kind of ideas to why this might be? And do you feel like this procedure might stand out more than some of the other alternative options?
Well, I mean, I think if you have irregular hours, perhaps, you may end up eating right before you go to bed. It really depends a little bit on sort of as Adarsh was mentioning, there's a lot of reasons why someone may be predisposed to reflux. Is it sort of issues related to relaxation of the sphincter? Is it sort of gastric yield pressure because you're eating a big meal and then lying down? There's other factors, but one important thing to remember is that with pharmacologic therapy, we are not really stopping reflux. You're still refluxing, right? We're simply just changing the composition of what's refluxing to something that's less irritating and injurious. And so there are certain things, we'll probably come to this later, like supraesophageal symptoms, regurgitation, other things like that, which pharmacologic therapy may not be all that helpful for. And where we're actually restoring sort of the anatomy, as Adarsh was referring to, may really be the preferred option.
Thank you for that. Dr. Sedarat, Dr. Thaker, do either one of you have anything else that you want to add to that?
No, I think, well, for me, I think what it brings up is GI symptoms and stress are closely linked. And I think you have to be careful applying an invasive therapy for some things that may be functional and stress related. Not saying necessarily that is in that case, but in any situation where you're going to apply TIF, for example, in this situation or any other invasive procedure, you want to make sure you have the right diagnosis. So if you have a stressful shift work, erratic situation, it would be important to document symptoms, go over symptoms that you think are going to get better with an anti-reflux procedure. And finally, confirm true pathologic acid reflux with pH testing. A lot of folks have, I think, heartburn and dyspeptic symptoms, maybe worse with stress, may not be necessarily, addressed with the barrier. And so it's not a great way of diagnosing IBS of doing a TIF and they don't get better.
No, that's a great point. That's a great point. I think before we kind of move into speaking about, speaking about TIF and CTIF, I think Dr. Muthusamy, maybe you could kind of set the stage for us on, how did we get to this point, and what's a brief history of some of the other endoscopic therapies that have come before, and have they kind of given endoscopic therapies a bad rep, and how are we overcoming it?
Yeah, sure. I mean, I think that, the graveyard of anti-reflux devices is large. And, We know when I was a fellow, actually, was when a lot of these technologies initially gained FDA approval or early adoption. And so there were thermal techniques where you sort of use radio frequency energy to thicken the GE junction, although it probably didn't work that way. It probably reduced TLESR. So that's sort of the Stretta technique. There was early attempts at endoscopic fundoplication, which were probably today comical because our suturing devices probably go deeper than those devices, which probably were barely beyond the mucosa. And so naturally they had very poor durability. And then there was even a thought, almost like you were doing Restylane lift injections, we would inject agents into the GE junction to plump up the GEJ, and this was the Enterix device at one point, and of course, or injection. And unfortunately, the aorta sits just behind and to the left of the esophagus, and there were some transaortic injections and renal emboli and sort of issues. So due to lack of efficacy or due to adverse events, essentially all of these technologies feigned to gain adoption. I would say that the Stretta technique did have some promising data, but the randomized trial, the sham trial, which was actually important because that was really at that time the first time any GI device trial had ever had a sham associated with it. And we learned that the sham effect for reflux is approximately 40%, similar to irritable bowel. So that study turned out to be negative. So the long story short was that while there was a lot of enthusiasm for this 20 years ago, it sort of faded. And then really it's sort of version 2.0 in terms of what we learned came about around 2010. And that sort of has led to sort of the next sort of set of devices. And of course, TIF and esophagus is at the top of that.
That's great background. Thank you for that. I think now that we kind of have an understanding of how we got to this point, can you kind of speak to like why TIF and why CTIF now, and maybe also kind of give us the background of the difference between the two procedures?
Yeah, I mean, I think that the TIF procedure is kind of creates a 270-degree fundoplication, and it's had various versions. There was originally years ago, it started around 2000, the late 2000s, with something called endoluminal fundoplication, and then it sort of endoluminal plication, and then it became TIF 1.0 and then TIF 2.0. And the current version, instead of doing a gastrogastric plication, actually tries to go up into the esophagus and does an esophagogastric plication, tries to create a 3 centimeter long valve, and it has increased the number of sort of the, these 5 serosifuse fasteners that we place to, over 20, 23, 24, sometimes 30. So we've significantly increased that, and that's, I think, had been an important device modification and technique modification, I should say. The other important thing is I think respecting the hiatal hernia, and that gets to the issue of TIF versus CTIF. And I think that there's lots of data. I just recently heard a surgeon say that the correcting the hernia may be responsible for as much as 80% of improvement in when you're sort of correcting the anatomy, as the issues that Adarsh was talking about in terms of the overall problem. And I think in the old days, perhaps we may have been a little too ambitious in trying to entirely do endoscopic approaches to patients who had 2-3 centimeter hernias. And probably, I think Ali's going to talk about the importance of endoscopic assessment for candidate selection. But I think we probably took some people who probably would have benefited from a hernia reduction and try to do a straight TIF. And so, those patients, probably had worse results. I'll come back to the results later, but I think the key issue here is a straight TIF can be done without a hernia reduction with 2 centimeter or smaller hernias. But if the hernia is 2 centimeters or larger, or if there's a larger, Hill grade valve of 2 or more, it really should be more than 2, I should say. Then it really needs to undergo a combination procedure where you do a hernia reduction, crural repair, and then subsequent TIF, all in one procedure in the operating room, but sequentially.
You mentioned that it's important to address the hernia repair, and obviously there are other procedures that do that as well. How does CTIF compare to some of those more traditional procedures like the Nissen, and what are some of the advantages that it can offer as far as post-op outcomes?
Yeah, I think you raise a great question, because a patient may ask, well, if I'm already going to the operating room, why don't I just have them just do a laparoscopic Nissen and be done with it? And I think the answer to that is that, there's always a spectrum, right? You can make things too loose and not get efficacy, but not get side effects. You can also go too far and get too tight with side effects. And the idea is to be right in the middle. And I think that with the CTIF, what you get is you still get the endoscopic effect. You get the adequacy in terms of symptoms, reduction in pH, off of meds, but you don't get the gas bloat and dysphagia to anywhere near the levels you do with a tighter wrap, like with a traditional Nissen.
That's great background. Before we kind of transition into some of the expected outcomes and the patient journey, Dr. Thacker, Dr. Sedarat, do either one of you have anything else that you'd kind of like to add to the comparison between TIF and CTIF and how those procedures compare to other traditional procedures?
Yeah, so I think Raman set that up very nicely. That's kind of the same conversation I have with patients as I counsel them. And I think the first point is that, kind of alluding to what Ali said, is that patient selection is vital. And so if the patient does have a wide diaphragmatic hiatus, which is reflected by the Hill grade, or a large hiatal hernia, as you can see during their endoscopy, I think you should consider kind of discussing that TIF is not right. It's really a CTIF or a traditional surgery. And then I have that same type of thing where in some patients, the Nissen fundoplication or other wraps may be too tight, whereas what they have now is too loose. So it's kind of CTIF may be the Goldilocks situation, where they get the repair of their outside valve with the hiatal hernia repair, and then we can take care of the inside valve. And it's a little bit different wrap. We call them both fundoplications, but really, when you look at what TIF's doing, it's kind of recreating those three parts of the anatomy, or CTIF, I should say, where the surgeon will reduce the hernia, tighten the diaphragmatic hiatus, and then the TIF procedure adds the length back. It does reduce the diameter of the lower esophageal sphincter, kind of high pressure zone, and also recreates that angle of His. You get that nice floppy flap valve. And so it's almost going back towards what your normal or natural anatomy should be. So it's kind of bringing you back towards that. And if the patient says, well, I want the thing that's going to be the tightest and extremely durable with the longest term data, then I'm going to say, then you should definitely consider a Nissen fundoplication, but there's trade-offs with that. And so while certainly I don't think anyone would argue that it's going to be as strong as a full complete wrap of the fundus around the lower esophageal sphincter, that may be not the right thing for that patient, because you talk about the trade-offs and potential downsides. So it really is a discussion with the patient and what their goals are. And I think that sometimes our goals as physicians don't necessarily align, where we want to get the most robust, pH control where there's absolutely nothing refluxing back, but that may not be completely in line with the patient's goals. And that's kind of the conversation I have when they're considering which way they want to go in terms of the surgical option.
Thanks, Dr. Thacker. We have a question, and Dr. Muthusamy, I'm going to send this over to you, because I know that you were planning to cover this. Scott is asking, what is the durability of CTIF compared to traditional fundoplication? So maybe with that question, you can cover that answer as well as some of the additional expected outcomes.
Yeah, important question, and obviously, if you take a look at the history, especially of the TIF 2.0 procedure, which is essentially what we do now, the most data we have is probably around 10 years, and we're starting to see, there's this 8-year follow-up study and there's a 10-year study that have sort of looked at this right now. And if you take a look at the durability data in the 10-year study, about 92% at 10 years with 10-year follow-up had stopped or halved anti-secretory use. So, like any procedure, there's going to be a little bit of decay. You get that with any surgical procedure as well. And that's lap Nissen would have the same. An 8-year follow-up study, with 23 that had very long-term follow-up showed that 3/4 were on some level of anti-secretory, which meant that they could even be just taking an antacid, but 80% remain satisfied with their reflux management. So that gets to your specific question. I'll just go back to some general data about TIF. You might say, well, what can you tell your patient? When we measure effectiveness, we usually judge it in one of four ways. Do you feel better? Quality of life. What about your ability to get off medications? Okay, can you stop your PPI, which is a big concern for a lot of patients these days? The third is, can you normalize the acid reflux? And then the final thing is what about symptoms above the esophagus or in the throat, my hoarse voice, my cough, my asthma, these other sorts of things. And if you take a look at those comers, you can see that you can probably normalize acid in between 40 and 80%. And I'll tell you that there's one study that looked at this issue and found that if you appropriately took care of all of the hernias with a hernia reduction, that 95% of people were able to normalize their pH with the TIF procedure. So I think it just goes to show you how important fixing hernias are. But the TIF appears to be superior to PPIs in eliminating or reducing regurgitation or supraesophageal symptoms. It appears to have better quality of life scores compared to sham and even fundoplication because you have fewer side effects associated with it. And so if you see that based on, and about 80% of patients who are getting this procedure are able to stop their medication. So I think it's shown some impressive results with all four of those key metrics.
Thank you, Dr. Muthusamy. Scott, if you have any follow-up questions to that response, please drop that in the chat and we'll be sure to address it. And with that, I think this is a great time to kind of transition a bit more over to the patient journey. And Dr. Sedarat, I want to direct this one over to you, but can you tell us a little bit about patient selection and how that fits in to the patient journey?
Sure. I have a little picture I can bring up if I can share my screen.
Sure, absolutely.
Let's see. Share screen. There we go. All right. Are you guys able to see that sort of classic hill grade?
Yep.
From 20, 30 years ago. So just put that up in the background as you think about the anatomy. But before that, I think you want to sort of think about the symptoms that you're looking to address, why the patient wants it. It's been brought up a little bit, but it's important to document, do they have typical reflux, atypical reflux, esophageal symptoms, extraesophageal symptoms, what responds to PPI, what doesn't respond to PPI, if they're not on maximal PPI therapy once a day versus twice a day, trying to really tease out what are we talking about when we talk about GERD, reflux, heartburn. I find that a lot of folks, these things mean different things. And if you tease apart, a lot of folks may be referring to dyspeptic or functional dyspepsia symptoms when you're talking about heartburn. You want to try to avoid those things. If there's a significant dysphagia component and a PPI unresponsive heartburn in quotes, that should be investigated for dysmotility. So just kind of that basic, bread and butter GI stuff should come first. But once you've decided that the patient has what you would consider GERD, kind of looking at what are the symptoms that you can probably do better than a PPI. And there's good data, randomized controlled data, that a anatomic repair does better with the regurgitant type symptoms, the gravity dependent sort of, physical symptoms above just the burning symptoms. So I think the ideal candidate is someone who they have, relatively typical symptoms. They get in a PPI, perhaps the burning is different or better, but if they bend over or if they lay down, there's still a disturbing regurgitant of stomach contents that may not be super acidic or sour or noxious, but still disturbing enough to impair quality of life. That may be accompanied by extraesophageal symptoms such as bronchospasm and hoarseness and upper sort of aerodigestive symptoms. I think you have to be wary of the patient who has atypical or typical symptoms and 100% doesn't get better with the PPI. You know, that may be something of a red flag. And those should be investigated, you know, closely to determine if they have functional heartburn that maybe responds better to a TCA. So, but after you've decided that they historically have reflux, the next two steps are what is their anatomy and what is their physiology. And so the anatomy here, this is probably of the branching points, perhaps one of, if not the most important when deciding about TIF in particular and anti-reflux procedures and surgeries in general. So this is the Hill grade system. Foregut surgeons and increasingly esophageal or interventional gastroenterologists are familiar with this, but generally general gastroenterologists aren't familiar with this. It is a means of classifying what the gastroesophageal valve is doing and how competent it is. So you're in retroflexion with the scope kind of pointed towards the fundus and the lesser curve and the scope kind of at the 12-ish o'clock position. And you sit there and you insufflate gas for a solid minute of just sitting there. And that's important to properly distend the stomach so that you can really get a sense of the valve. And so the valve is characterized this way. Grade 1 is two things. One is that there's not much space around the scope and the gastroesophageal junction. You can feel it kind of hugging without looking up into the squamocolumnar junction. And there's a ridge, there's a verticality at the angle of His up the fundus. So that's, if you can see, I don't think you can see my mouse, but that's the ridge that's sort of diagrammed there. And as you go through the Hill valves, that ridge flattens or effaces. So in the Hill grade 2, it's a little flatter, and with respiration, there's a little bit of space between the scope and the esophagus. So it's not quite kind of a hiatal hernia or a patulous valve. That's not quite tight. So 1s and 2s are kind of your cherry for pure TIF. If you can find them, go for it. Confirm that they have acid reflux with pH-metry, and they'll probably do very well without any hernia component of repair. The bottom half on this patient journey is those that may need to consider something else or something in addition. So if someone has a Hill grade 4 valve, that's just a sliding hiatal hernia. Kind of, you can see it from a mile away. Those patients are probably better served with traditional anti-reflux surgeries, either a toupee and Nissen. The larger the hernia, probably more likely you're going to be in a surgical fundoplication. If they have a relatively smaller one, you could argue doing a C-TIF. And the 3s are kind of the perfect person for a C-TIF. There's a fixed, dilated, patulous gastroesophageal junction with, irrespective of respiration, space where you can fit a couple scopes perhaps between the scope and the gastroesophageal junction. And that ridge of the angle of His is effaced. And so in those patients, there's often a phrenoesophageal laxity. There's often an axial component of the hiatal hernia, meaning that the hiatus is patulous and requires some buttressing with the surgeon. But then your ability to reform the flap valve in the angle of His is much more effective when that's done. So once you've determined, so that anatomy component, it just takes a second more than you're used to looking in retroflexion of insufflation and good pictures. And it makes a big difference in your decision process. And the final thing should be pH studies off of a PPI. 48 hours is great. If you can do 96 hours off followed by on, just to see that they appropriately suppress acid, that's of interest perhaps. But mostly you just want to confirm that there's pathologic acid exposure. And to me, the utility there is to identify those folks who are potentially in the functional heartburn realm where doing an invasive procedure is unlikely to help them. And you know, if there's a side effect, they'll probably have them. So you want to maybe think about avoiding those folks.
Thank you, Dr. Sedarat. Those are great points. I do have a follow-up question for you. You mentioned the importance of assessing the Hill grade, right? And kind of just provoking it, giving it the time to really show itself. So I guess for both you and Dr. Sedarat, could you, I'm sorry, for you and Dr. Thacker, could you kind of go into how often do you have an idea of what the Hill grade is going to be? And then after waiting, you see that it's something completely different, to really kind of highlight the importance of provoking it so it can really show itself.
Yeah, I mean, I think you can make it look kind of like almost like whatever you want it to be, depending on how much you insufflate, you know. And so I would say almost always at inadequate insufflation, you will underestimate the Hill grade as a 1 or a 2, when in fact it may be a 3, almost invariably. So it's very important to sit there and insufflate.
Yeah, and it's really the worst image you can catch is really what the measurement is, because again, sure, it may be you're only seeing it for a second, but if you catch that, it's really important that that's what you define it as, because the decision-making process and the outcome is going to be based on that. So if you do a straight TIF on someone who really needed a C-TIF or a traditional surgical fundoplication, they're going to come back and they're not going to have effective response, and they may let you know it.
Thank you, Dr. Thacker. There's another question in from the participants here, and it is, what's the learning curve for a general GI? And do you feel it can be done in more private and community settings? And I see that there's also a question about paying and reimbursement. And just for the sake of time, we don't have the time to go into it, but I will include that in a follow-up email out to everyone who's participated. So Dr. Thacker, Dr. Sedarat, could you maybe highlight the learning curve for us?
Yeah, I think probably, yeah, it's a little bit of a strange procedure because you're doing it completely in retroflexion, and so it kind of combines the principles of a savory dilation, and then and really having some comfort scoping entirely in retroflexion. And so I think that those are really the prerequisites. So really having a good device, and then really this is your view the entire time, but you also have a 60 French device that has to make it through the esophagus, and the placement is critical. So kind of when I'm thinking about who can do this, I think it's one, being prepared to deal with complications if there is something. Knock on wood, we haven't had anything like that, but it is a pretty large device. And then two, just having the kind of the spatial awareness and the ability to kind of view things in retroflexion. So I think it can be done. I don't necessarily think it needs to be an advanced endoscopist, but I think some may be more used to doing things like doing polyp resection completely in retroflexion. Dr. Sedarat, who performs ESD, certainly is no stranger to that. And then in terms of what setting, here in California, in Southern California, there are private practice physicians performing this in community hospital settings. Many of the community hospitals around here have been doing these procedures for years, and our surgeons in the community have also commented on they love doing the C-TIFs. They get to kind of very efficiently set it up where sometimes they'll have 2 rooms going. The surgeon will get started on their hiatal hernia repair, do it quite quickly. Gastroenterologist takes over and does the TIF while the surgeon gets started on a hiatal hernia repair number 2. And it's kind of the best of both worlds. They both are doing procedures. The surgeon doesn't take the phone calls for all the symptoms and side effects after their Nissens. And so there's some surgeon GI pairs that have completely switched from doing Nissens to doing C-TIFs. And that's certainly true at some of the academic centers, but also for sure in the community.
Yeah.
Thank you, Dr. Thacker.
Yeah, I think what's interesting about this technology is that it's almost a prototypical category of itself with endoscopic interventions, because for the most part, when we're talking about interventional endoscopy, the endoscope is still the horse you're riding, and it's still the animal that you have to control to do what you want to do. With this particular device and technology, the endoscope is just a camera, and the technology is a dedicated disease-specific intervention. So you don't necessarily need to know anything about EUS and ERCP and ESD and all that kind of stuff. You just need to kind of control the camera And ironically, you don't really have to control the camera; the other guy does. Which can potentially be frustrating if the person who has their hand on the camera doesn't know what views to obtain. So really, a general gastroenterologist who's savvy enough with technology and devices can certainly learn it. I think there's a learning curve of probably about 10 to 20 cases of being kind of comfortable with it, if I had to guess. It's worth watching a few cases live with someone who's willing to answer questions, get a model in your hand with something plastic or just to get a sense of the steps. And it's just a sort of kind of air traffic control steps of doing something in a very ordered and logical way. And the learning curve is really understanding what those steps are doing within the body and anatomically what you're trying to achieve so that you can make adjustments to achieve success.
That's a great point, Dr. Sedarat. And I just want to reiterate that, as you go through those, those first 10 to 20 cases and you're getting, becoming an expert and feeling comfortable, we do have clinical specialists who will be there to support you along the way, making sure you feel comfortable in the procedure and that you are making great clinical choices for your patients. Next question we have is from Nadine, and they would like to know if you both feel like we are going to see the TIF procedure as a new primary treatment for GERD kind of moving forward.
Yeah, go ahead. Go ahead, Ali.
Beauty before age. Go ahead.
So I think that it's tough to say that it's going to be the primary because, frankly, PPIs are still very effective, and I think most gastroenterologists will agree that in appropriately selected patients who actually have GERD and not functional dyspepsia or functional heartburn and other conditions that may not respond completely, they're still considered safe. And so the side effects, there's a lot of worry, but I think those will still be king. But I think that TIF is a nice new option. And one of the things I talk to the surgeons that maybe are more married to traditional things is that these really often are different patient populations. We're not pulling from the same people and saying we're going to take the Nissen patients and move them. Oftentimes the patients I get are from primary cares or general gastroenterologists, and they're patients that thought that the Nissen was too aggressive for them and they never would have considered anything else. And so it's really kind of, there's a huge pool of patients with reflux, and it's a different set. I found that the patients that come see me have already done their own research on this and knew they didn't want a Nissen or something like that. So while I don't think it'll be primary, I think it's a nice new option and kind of that Goldilocks option, like I mentioned before.
Yeah, that's right. I mean, I think there's understanding and approaching reflux as a spectrum. There's this big gap in the middle that's just underutilized, and folks just kind of deal with it type of a situation. They're just on medications and maybe don't have excellent kind of control of their symptoms or their quality of life. And those are the folks that I think we were just waiting on the technology that would be appropriate to capture. And we've been waiting for, there's a graveyard of anti-reflux devices that were trying to find that niche and satisfy that gray area over the last 20 years. And it seems that, the esophagus device has satisfied a lot of those requirements to fill that niche and has stood the test of time. And we took a long time before we adopted it, waiting for data to come out, the 5-year stuff, because there's hesitancy with that space because of the history, and it seems like it's something reasonable to consider. So I think it's maybe not something that every single reflux patient should go on, because every reflux patient probably doesn't need it. The folks that maybe just once in a while you overeat, you need to take your PPI, that's fine. But if you have daily symptoms, and if you don't take your PPI, you're a miserable person. Those patients would just kind of hang out hoping for something, and this might be filling that need. On the other hand, the folks that have severe anatomic derangements are still going to find their way, hopefully, to a surgeon and get the appropriate care.
That's a great point. Thank you so much for that.
Yeah, one thing I'll add kind of as kind of a global thing is I think to that end, really there's different levels of how much we want our referring physicians to take care of before. But if I'm talking to a primary care doctor, I'm really just asking them to answer one question, the patient, and them to ask the patient, are you willing to undergo some type of procedure for your reflux symptoms? And if the answer is yes, then I'm happy to see them and then kind of go through all of these various options. And so that may be a patient that may not have been captured for anything before, but now we can kind of lay out what spectrum they have.
That's a great point, Dr. Thacker. And I think it leads in kind of to another transition, which is what are you guys doing at UCLA to educate primary care physicians and your referring colleagues that there is something more that can bridge the treatment gap, and here's what you need to know about it?
Yeah, so there's so it's kind of it depends on kind of the audience. So with the primary care, it's I leave it pretty straightforward, and I think it'll depend on whatever your own institutional kind of setup is or what your referral practice is. But here in LA, we have some geographic limitations that you don't want necessarily patients to go through multiple procedures or drive different places if they're not. So there's two ways of thinking about that. One is we try to get the gastroenterologist at UCLA that's closest to them to do as much of the workup before they come see us. So the primary care would refer to them. But on the other hand, maybe they don't evaluate the Hill grade properly, or there's some discrepancy on the hiatal hernia from one study to another, where I have to repeat the endoscopy on my own anyway. So I think that myself, Raman, and Ali have kind of slight variations of this, but I typically just have the primary cares just do that screening question, that would a patient be willing to undergo some type of procedure up to and including surgery? And if the answer is yes, I kind of start and I take the workup early on, doing my best to screen out kind of the functional patients and the patients with very high BMI, et cetera. But there are other gastroenterologists who are interested in this field, and they do a very good job evaluating the GEJ. I know of some institutions that will actually have the referring GI do a video recording of the Hill grade and then send it to the person doing the TIF, so that way they could assess the Hill grade, without having to repeat the endoscopy. So we're kind of doing an education front on both. So for primary care, just letting them know that there is another option, and it's not just surgery or PPI. And then for the general gastroenterologist, it's teaching them how to do some of this workup and assessment.
Yeah, I there's a question that came up there from Dr. Hashamipur that I think is a really good one, and I want to make sure, because I think we're running out of time, to make sure we address, which is relapse after TIF or CTIF. And I think that brings up two important points, which is that the first is that none of these anti-reflux procedures have a lifetime warranty attached to them. At the 5 to 10 year mark, a lot of things will start to slip and loosen. Hiatal hernias recur, despite what a lot of surgeons would like to believe. Most of them, accept that things slip over time, and so you have to strategize with that. And there's a couple of ways that I think is useful. And so the second point is that it's far easier to revise a TIF that's worn off than a Nissen that's worn off. Or a toupee is pretty much the same, that's worn off. So a failed Nissen or a Nissen that was fine for 5 or 10 years and then worn off, for a surgeon to revise that's a relatively big deal operation that usually gives like a collective groan during multidisciplinary conference. If a TIF relapses, then the dissection, if there is going to be surgery, of the hiatus, the dissection of the fundoplication to revise it. It's not as easy as a virginal case, but it's much easier than revising a slip Nissen that's very old. And endoscopically, there is experience that's growing, some in abstract form, some in kind of just anecdotal form, of people figuring out how to bring their TIF patients back and augmenting their valve with some anecdotal success. So the answer to that question is that they can be revised case by case, probably re-examined endoscopically, perhaps barium swallow to get a sense also of some complementary anatomy. If they're having new symptoms, try to get a sense of what are those new symptoms. Are they truly attributable to reflux? And then if it looks like the valve can be endoscopically lengthened or tightened with a TIF, there's not a whole lot to lose to try that. And if not, they've burned less of the bridge compared to if they had a Nissen 5 or 10 years ago, and then the surgeon wants to revise to a Nissen again.
That's a great point. Thank you, Dr. Sedarat. Just to be sensitive of everyone's time, we've gone almost 15 minutes over, and there's still a handful of questions that we haven't been able to address. So really quickly, I just want to, I dropped some information in the chat for you. First of all, Dr. Muthusamy has done a TIF talk of his own, and I dropped a link for you to see. It has slides that encompass the anatomical and outcome discussion with clinical data. I've also included a link to our YouTube channel, which has other peer-to-peer discussions as well as live cases. So if you're maybe looking to see what this looks like in action, you can do that as well. There were some questions about reimbursement and payers. I've dropped a link to our website where you can get some just basic information on that. And if you have any additional questions that we didn't get time to cover tonight, you can reach out to marketing@endogastricsolutions.com, or to make it easier, you can just respond to whatever confirmation email you received for tonight's event. We do host these on a monthly basis. The next one we're hosting that I can confirm is on June 23rd with Dr. Phoenix Nguyen and Dr. Caitlin Houghton, also out of the Orange County area. So with that, I want to say thank you everyone for your time and your engagement. It's been a great conversation. And to Dr. Thacker, Dr. Sedarat, and Dr. Muthusamy, we really appreciate you taking the time out of your evening to address such an important topic.
Okay, thanks.
Yeah, great. Yeah, thanks for having us. I know there's some great questions that haven't been answered, but we're always happy to chat offline as well. Thank you so much.
Thanks, everyone. Have a great evening.